Welcome to St. Louis University Geriatric Education Center's Train the Trainer sessions for cognitive stimulation therapy. My name is Julia Henderson-Kalb, and I will be with you for this first video session. In the session, we are going to discuss what exactly is cognitive stimulation therapy, the history and research behind it, the key features of cognitive stimulation therapy, and a general discussion of how CST sessions are structured. As I said, my name is Julia Henderson-Kalb, and I work in the Department of Occupational Science and Occupational Therapy here at St. Louis University. And I'm presenting Module 1. Sue Tebb is a professor at the School of Social Work at St. Louis University, and she will be presenting Session 4. Janice Lundy is the Director of Social Work and Geriatric Case Management at Perry County Memorial Hospital, and she will be presenting the final 5th module in this presentation. Debbie Hayden is the Director of Occupational Therapy at Perry County Memorial Hospital, and she will be presenting Module 2. Daniel Stewart is a doctoral student in the School of Social Work here at St. Louis University, and he will be presenting Module 3. Other participants in our team, which is an interprofessional team of healthcare professionals, include Marla Berg-Wagner, who is a professor at the School of Social Work here at St. Louis University, Max Zbaski, who is an assistant professor in the Department of Family and Community Medicine here at St. Louis University, and Michelle Sakamoto just graduated with her MSW in the School of Social Work, and Laura Downing is a Master of Social Work student, both here from St. Louis University. Before we really begin, we want to acknowledge Martin Orrell and his team from the UK who created cognitive stimulation therapy. They tested it, they validated it, and they allowed us to create these training sessions to make it easier for you to implement your own cognitive stimulation therapy training here within your own programs. So, the definition of cognitive stimulation therapy, to start with, is an evidence-based group of interventions for people with mild to moderate dementia. CST provides guidelines for structuring small, theme-based group sessions aimed to actively stimulate and engage while providing an optimal learning environment and the social benefits of a group. We are now going to show you a short video on CST as it was implemented at Perry County Memorial Hospital.
People enjoy talking about their past, but it's talking about the past and bringing it forward into today, and the things that are going on today is what's really makes it effective.
When I think about what we're doing with the participants, it's like turning lights on in their brain. You have them pull up an idea, and then you have them connect that through facilitation and through activities to a new idea.
People with dementia are still able to learn, and I think that's what people don't understand, that they think there's this memory loss and they can't learn anymore, but in the right environment they can still learn.
And the more you can turn those lights on, the more the person is there and the more they can use the different parts of their brain to problem solve and to communicate and to understand. And
we're an organization that constantly looks into our community for ways to serve them more, and we've always had an emphasis in care for the elderly.
Well, it's great. I would recommend it for anybody. Before I came here, I had a little TIA stroke. I couldn't remember stuff, I think that's everybody's problem. But just after I was going to this class, I don't know, maybe 3 or 4 months, my family really noticed that I was back. I could remember most everything,
When she got involved with this, she's just like she's come back to life. She's talkative, she wants to be around people, where before she didn't want to do that.
It keeps me active. I don't just sit around and wait for something to happen. Well, they're all very, very friendly, and we all get to know each other.
I think it has opened up his life more. I really do. I think he's more receptive, but I think he opens up more, probably, to talk to people. And he enjoys this class. He really does.
I think CST is really just on the forefront of dementia treatment. We have excellent leadership with Janice Lundy, and I'm so proud to be a part of this program.
So speaking a little bit about the history of cognitive stimulation therapy, it was created largely by Amy Spector, Martin Orrell, and Bob Woods. And initially they started off with just a literature review about non-pharmacological therapies for people with mild to moderate dementia. They took the best of what they found in the lit reviews and they combined it with reality orientation to try to create this really effective program called cognitive stimulation therapy. And cognitive stimulation therapy is the only non-pharmacological program of intervention that is actually approved by the United Kingdom government and the National Institute for Health and Care Excellence. And not only is it approved, but doctors in the UK, once a person is diagnosed with dementia, they automatically refer them to a CST program, regardless of any drug regimen. So after they did their lit review, they started a pilot study in 2003, and they wanted to see what that would do. They wanted to compare people who had the cognitive stimulation therapy against people who did not have cognitive stimulation therapy. And this pilot study, it kind of showed significant improvements in cognition and quality of life. And it was similar to the intervention developed in Japan called SATO. Now, SATO is a program where a caregiver is trained to work with two people with dementia, and they are seen 5 times a week for 30 minutes at a time, and they do arithmetic and reading and writing, very basic. And it's not so that they will learn new things, but it's just to engage their minds. And there was a lot of improvement in cognition at bedside for people who worked with this. But cognitive stimulation therapy had pretty even cognition level improvements, but there were also improvements with quality of life, according to the quality of life indicator with Alzheimer's disease. So when they did their original study, they had 23 centers and 201 participants with a diagnosis of dementia. They were randomly put into 2 different groups, one with CST and one with no treatment control group. And the results demonstrated that there was a significant benefit to cognitive and language skills, including naming, word finding, and comprehension for those people who were in the CST programs. Where we are concerned, where St. Louis University is concerned, we have started to do more research and try to continue to validate some of the findings. We have been working with Perry County Memorial Hospital, and we have been doing this research, and we have been doing pre-tests and post-tests based on the SLUMS, the St. Louis University Mental Status Exam, the Cornell Scale for Depression and Dementia, the Quality of Life with Alzheimer's Disease assessment, and the Timed Up and Go, a balance test and a gait test. Some of the first research we did, if you take a look at these charts, demonstrate that after 7 weeks in cognitive stimulation therapy, there were significant differences, statistically significant differences in pre- and post-test regarding cognition, as reported on the SLUMS. It went from a mean of 16.38 improved to 19.57. Depression was significantly reduced from 6.08 to 3.94, and quality of life was significantly increased from 33.46 to 37.75. So those were all very statistically significant. There is also a maintenance program with cognitive stimulation therapy, and you will hear about that as these modules continue. And although the results were not statistically significant, it was found that there was still slight gains in cognition and quality of life and slight decreases in depression on pre and post tests within these 6 to 12 months. And we did not have a group of people who were not going through cognitive stimulation therapy, but it is suffice it to say that having maintained for 6 to 12 months these levels and even slightly improved can be considered a significant find. Not only did we ask the patients or the participants in these groups whether, on their depression and their quality of life, but we also asked their caregivers to do the same pre-tests and post-tests. And it was found that they were fairly similar in their findings, that the caregivers also agreed that depression decreased and quality of life increased with this cognitive stimulation therapy. This past summer, we did a little bit more. The slides that I just showed you were about a year ago worth of studying. This past summer, we did a few more groups, and we again found some statistically significant findings regarding cognition and depression. Quality of life improved, but it was not statistically significant. And the timed up and go also, with timed up and go, you want a decrease in the amount of time it takes to walk a certain distance. So that time did decrease slightly, but again, not statistically significant. So, how are you going to develop and implement these CST groups? Well, to start with right now, we are going to just discuss the key features of the program, what it is, so you can kind of get a basic idea of how things go. Cognitive stimulation therapy, the original program, is a 14-session program, and it's usually done twice a week, which means that it's a 7-week program. Normally, it's 45 minutes to an hour. If you add an exercise component, which you will also hear about later in a different module, then obviously it would be a little bit longer than 45 minutes to an hour. But you can incorporate that as you have time. Ideally, there's 5 to 8 people in a group, and there are 2 facilitators. Who those facilitators are can vary. It can be an occupational therapist, a physical therapist, a speech therapist. It can be a social worker. It can be an activity director. Really, anyone who wants to be trained in this can be trained in cognitive stimulation therapy and participate as a group leader. We have found thus far in the United States that the only people who can charge for these sessions would be occupational therapists and possibly physical therapists at a group rate. And regarding if you want payment. But if you go and you get a grant, or if you're doing it without expecting funds, or if you have people pay for this, then obviously that's a little bit different. But ideally, there are 5 to 8 participants, and there are 2 facilitators. Each session has a choice of activities, and you want to try to gauge your group and see what kind of interests and abilities they have and kind of go from that. And again, in future modules, you will hear a little bit more about how to do that. Group members should ideally be at similar stages of dementia so that the activities can align with all of them. If you have anyone who is has very high cognition and the rest of the group is lower, they can get bored. And if you have a person who has lower cognition than the rest of the group, then they might not understand what's going on, and they might start to get depressed or pull out from the group, and they would not be participating as much or frustrated. So if you can get a group that has similar dementia stages, that is really ideal. And you should also consider the gender mix. Sometimes an all-male group is beneficial, sometimes an all-female group is beneficial, but sometimes it's nice to kind of mix males and females. And so just kind of having an idea and realizing that your groups will be slightly different depending on what you do there. So how do these things work? How do these sessions work? Well, just to give you a basic idea of how they go along, and you will, if you look at the manuals that you will hear about in future modules, then you will see that they really break down very nicely exactly what you do with each session. However, for right now, I'm just going to give you a brief introduction on all the different areas. Every time you start with an introduction, You go to a theme song, you have current affairs, a main activity, then you have a suggested activity for home and closure. And I'm going to kind of briefly go into each one of those. So when everyone comes in to your cognitive stimulation therapy group, you want to welcome them. Name tags should be incorporated into your sessions because that way it does not give people pressure of trying to remember names. They can glance at the name tag. They don't have to feel the pressure of remembering those names. You want to welcome each member individually, possibly hand them their name tags at that point. It kind of orients those people to, this is the start of the group, these are my colleagues who are going to be here, and it kind of fosters that rapport that I'm welcome here and it's a safe place. You will then go on to state the name of the group, and this name is chosen by the group members on the first session. So when the first group meets, you say, what do you want this group to be named? And they can come up with anything. There have been the All-Stars, there have been the Forget-Me-Nots, there have been, all kinds of different names, but it's what the group kind of talks about it, they choose it, they agree upon it, and then that's the name for the rest of the sessions. The great thing about how you start these sessions and how you continue them is that they are very structured. And so the group members will come to expect you to welcome them and then to state the group name. And then to go on to the softball toss, which is the next part. Again, it serves as an orientation process. What you do is you get some sort of a beach ball or a softball, and you have each of the group members state their name, toss it to somebody, and you can add something to it after your group gets going, like say something happened this week, or say something happy, or something that makes you laugh, or you can just ask them to make a comment as they're tossing it. And then they toss it and they can say the next person's name that they're throwing it to. And if they forget, that's fine. You remind them of it, and they have the name tags to kind of help orient them to that. After you go through the softball toss, you will reference the day, the weather, and the season. And you should always have an erase-it board when you're starting these sessions so that there is visual cues along with your verbal cues of what's happening. Again, having that orientation to what's going on, not only in the group, but surrounding outside. And then just kind of having a discussion, asking if anything's going on and people want to talk about something that's happened in their lives since the last session. This fosters, again, camaraderie with the group, and sometimes there can be really great things that come from that discussion. After you go through the introductory portion of the group, everybody will then sing the group's theme song. And again, this is on the first session. That theme song is chosen. It should be something that's short, or just the chorus of something if that's going to be if it's a longer song. It could just be the chorus of something. But again, they choose it if they struggle with trying to figure out what they want their name to be or what they want their theme song to be. Obviously, you can kind of give them some suggestions, but really, kind of try to encourage them to think of songs from their past, think of songs that make them happy. The All-Stars song was Take Me Out to the Ball Game. You Are My Sunshine is another good one. Happy Birthday is a fine song. But they just need to choose it on that first session, and then each time after the introduction, they sing that theme song. Again, it kind of just brings them together and makes them realize that this is a group that's going to continue to be working together. After the orientation and the theme song, then you move into more of the meat and potatoes of the group, and it starts with a current affair. So you take some sort of an article, some sort of a news article, and you will make copies of it for all of the participants, and you take it out. Somebody reads it, you read it, however, depending on the group and how well they can read, and you talk about it. You kind of discuss What would you think about this? It's very important with cognitive stimulation therapy. One of the main things about it is that you're not asking for right or wrong answers. You're not asking them to, after you finish the article, you're not going to quiz them on what was in the article, but you're going to ask them about their feelings about the article, or you're going to ask them to maybe think about something from their past that can relate to the article, or how was this done when you were a child versus what this article says now, or how can you compare what's going on now to then. So it's bringing that information from the past and pulling it into the present. Human interest stories are always things that people really like. They can be local, talking about if you're in a small town, talking about the local football team, or some sort of a philanthropic event that the high school put on, up to national stories. As you can see in the slide here, we're talking about, this is an article on same-sex marriage, which is obviously a nationwide news story. And the reason that we put this particular slide on here is that we don't want you to shy away from those controversial topics. When you first start the group, you want to gauge your group, and you want to gauge what they're willing to allow. But some of the best conversations that have gone on in these cognitive stimulation therapy groups for us have been when we have talked about controversial topics. And it's amazing how everybody stays pretty nice, and they don't get argumentative, and there's really a good discussion that goes on when you have those controversial topics. You really should, like I said before, print out an individual copy for each member so that they can be looking at it. And you want to make sure when you are talking about people with dementia, a good majority of the time they're older adults, make sure that the font size isn't so small that they're not going to be able to read it. And then you come to your main activity. In module 3, you are going to have kind of a discussion about what the main activity, kind of a role-playing main activity discussion. So you'll get a little bit better idea of what that is at that point. But the main activity for a session is, you can find them in your manuals to start off with, but it's okay to kind of veer from those if you feel like the group that you're working with is not going to be as interested. If you find out that your main activity is about sports and you have an all-female group that isn't really interested in sports, you can veer from that and kind of do a different topic. But it's very open to kind of changing it however you see fit. But what it basically is they will have a topic. Let's say it's sports, or it is, another one would be Christmas through the ages. And so you can kind of use all kinds of different sensory stimulations to create a time where they are talking about things from their past again and bringing it into the present. So an example, if you're talking about sports, you might have pictures of athletes from today and from yesterday. And they can talk about the differences, or they can talk about what was their favorite sport that they liked to play as a child, or how they feel like professional sports have changed from the time when they were younger to current times. So you just want to kind of get them talking about things, bringing those ideas from the past and bringing them into the present. But again, like I said, you can use multi-sensory activities. If you are doing a sports one, maybe not just bring pictures of athletes, but bring a baseball and a basketball and have them feeling that and touching it and smelling it and getting that sensory input. If you're talking about Christmas, you can bring eggnog or baked cookies and have the olfactory senses and even the tasting, and getting some other senses incorporated into your main activity. After you're finished with your main activity and after you're finished with your current affairs, you will go into closing the group for the day. You want to suggest things that the patient or the group members can do at home. And it's really best if you can have a copy of a handout that the caregivers or their loved ones can take with them, so that during the week they can kind of continue to incorporate some of the discussions that happened during your group during their daily activities, so that keeps that stimulation going throughout the week. And again, it could be you can make another copy, or you can have them take home a copy of the news article that was read aloud, so they can continue to discuss that. At the end of your session, after you've kind of talked about, after you've handed out your handout, talked about what you should kind of do at home, you have a time of closure where you discuss the time and the day and what's going to be the next activity for the next session. And if the group says, oh, I don't really like that activity, maybe you kind of change it, or maybe you ask their opinions on what they would rather do. But then they have an idea of what to expect the next time that they come. And then you kind of ask how you feel the group went that day, get any opinions back on that, and you end your session for the day. And that is basically a very short explanation of the session structures for cognitive stimulation therapy. You will continue on with Module 2 after we finish here today, and I thank you for your attention.